Idiopathic pulmonary fibrosis, or IPF, is a life-threatening condition with a median survival time of 2 to 3 years from diagnosis. The pathophysiology of this condition is not fully understood, though it is believed to arise through successive injury to the alveolar epithelial cell compartment. Risk factors associated with IPF include age, infective agents, genetic predisposition, smoking, and other airborne irritants. Cytokines and other mediators released by stimulated epithelium can promote aberrant wound healing, where the deposition and scarring process continues unabated. Fibroblasts and myofibroblasts play a central role in the deposition of extracellular matrix during this process, creating fibrotic tissue within the lung interstitium. Excess collagen deposition and the accumulation of myofibroblasts in response to injury distorts lung architecture and stiffens lung tissue, leading to impaired gas exchange, which progressively restricts the physical activity of a patient.
කලින් explain කරපු විදිහට lungs inward shrink වෙන තමයි හැම වෙලාවෙම බලන්නේ chest wall එක outward expand වෙන තමයි හැම වෙලාවෙම බලන්නේ. ඒ කියන්නේ chest wall එකේ elasticity එක තියෙන outwards යන lungs වල තියෙන inward shrink වෙන. එතකොට lungs වල inward shrink වෙන තියෙන elasticity force එක තමයි අපි overcome කරන්න ඕන lungs inflate කරද්දී. නැත්නම් respiratory system එක inflate කරද්දී. Respiratory system කියන්නේ lungs plus chest wall. එතකොට chest wall එක outward නම් move වෙන්නේ හැම වෙලාවෙම බලන්නේ lungs වල inward movement එක chest wall එකේ outside movement එකකින් අම්තරමක් දුරට resist කරලා තියෙනවා. එතකොට අපිට මුළු whole respiratory system එක inflate කරගන්න යොදන්න ඕන work එක සාපේක්ෂව අඩුයි. මොකද ඒකෙන් යම් කොටසක් chest wall එකනොත් කරලා තියෙනවා chest wall එකේ outward movement එකේ. හැබැයි lungs තනියම ගත්තට පස්සේ chest wall එකේ outward movement එකකින් යොදන බලය නැහැ. එතකොට සම්පූර්ණ බලය තියෙන lungs වලට inward shrink වෙන්න විතරයි. එතකොට අපි lungs වලට inward shrink වෙන්න යොදන බලයට වැඩි resistance එකක් යොදනවා lungs expand කරන්න. මොකද chest wall එකේ outside expand වෙන්න තියෙන බලය එතන නැහැ. lungs විතරක් තනියම ගත්තට පස්සේ system එකක් විදියට. whole respiratory system එක ගත්තට පස්සේ අපේ work එක plus chest wall එකේ outward expansion එක තියෙනවා lungs වලට resist කරන්න. but lungs තනියම ගත්තට පස්සේ අපේ work එක විතරයි තියෙන්නේ chest wall expansion එක නැහැ. lungs වල movement එක resist කරන්න. එතකොට වැඩි work එකක් අපි කරන්න ඕන lungs expand කරගන්න lungs විතරක් තනියම තියෙනකොට.
Hello, in this video we're going to talk about pulmonary circulation, and we will also talk about ventilation and perfusion. So first of all, ventilation is essentially the amount of air traveling into your alveoli ready for gas exchange. Perfusion is the amount of blood flow going into the alveoli and thus prepared for gas exchange as well. Ventilation is abbreviated V and perfusion is abbreviated Q. A simple concept to understand is that the lung is divided into 3 zones. The so-called ventilation-perfusion ratio is higher at the apex of the lung on the top. Towards the base of the lung, the ventilation-perfusion ratio is decreased. The ventilation here, again, is the amount of air coming into the lungs, specifically into the alveoli, ready for gas exchange. The perfusion is a blood flow to the lungs, to the alveoli, and thus ready for gas exchange. The average ventilation-perfusion ratio is 0.8. 0.8 really means that there is more perfusion, more blood flow to the lungs, to the alveoli, than there is ventilation. But fun fact, through the lungs, perfusion and ventilation differ. Different lung diseases can also further affect the ventilation-perfusion ratio, also known as the VQ ratio. Let's now try to understand the concept of ventilation and perfusion and why they differ in different zones of the lungs. So here we have 2 lungs. The heart pumps deoxygenated blood through the pulmonary artery into the lungs. In the upright position, the upper portion of the lungs are well above the level of the heart, and the base of the lungs are at or below it. This has important implications on the perfusion as well as the ventilation. Because as you can imagine, when standing up, gravity will affect how much blood goes to different areas in the lungs. So as mentioned, the lungs can be divided into 3 zones. As you can imagine, blood traveling to the zone on the top at the apex of the lung will be decreased because of gravity. There's decreased perfusion at the apex. Perfusion here is represented by Q, remember. This means that the blood flow to the base of the lungs will have increase in perfusion. So the Q is increased. Thus we can say that at the apex of the lung we have wasted ventilation. All the gas that goes to the alveoli is not exchanged efficiently because there is less perfusion. Whereas at the base of the lungs we have wasted perfusion. There is a lot of blood flow to this area but not as much ventilation, not as much gas going into these alveoli. Fun fact, like perfusion, ventilation is actually higher at the base of the lungs than at the apex of the lungs. Just important to keep note that both ventilation and perfusion is actually greater at the base of the lung. So let's look at another representation here. Because the apex of the lung sits well above the heart, you have larger alveoli. There is reduced pulmonary intravascular pressure because of less blood flow to this area. Less blood flow means less perfusion. In the apex, you also have less ventilation occurring because of your large alveoli. But despite the reduced ventilation, the perfusion is far more reduced here. And so you actually have wasted ventilation, which means you have a lot of gas, a lot of oxygen to offer, but not enough red blood cells around. As you go to the base of the lungs, your alveoli become smaller. The size differences in alveoli from the apex to the base of the lung is attributed to the difference in intrapleural pressure, which we won't actually talk about here. You have more blood flow to the base of the lungs as mentioned, and so you have more perfusion. At the base of the lungs, you also have more ventilation because the small alveoli are able to expand more. At the base, the ventilation increase is not as much as the increase in perfusion, and thus the ventilation-perfusion ratio is lower here. Thus, we can create a ventilation-perfusion ratio using this concept. So at the base of the lung, you have good ventilation and great perfusion. For the apex, you have not so good ventilation and pretty bad perfusion. This is again in an upright position, and these differences in VQ ratio is thought to be primarily due to gravity, but also other factors play a role, including different diseases. If this concept of different ventilation and perfusion is still confusing, let's take another look at it and introduce pressures. Again, you have 2 lungs. Each lung can be divided into 3 zones. The pulmonary artery brings blood to the lungs. The pulmonary artery pressure, P small a, here brings blood to the alveoli. The alveoli have their own pressure, represented as P capital A. Gas exchange occurs between the pulmonary vessels and the alveoli. Then the pulmonary vein will return this newly oxygenated blood to the heart. The pulmonary vein pressure here is represented by P small v. So now let's introduce the 3 zones again. At the apex of the lung, you have large alveoli. You have a large alveolar pressure. Blood flow to the apex is less, so pulmonary arterial pressure here is normally just sufficient to maintain perfusion. But if pulmonary artery pressure is reduced or if alveolar pressure is increased, some of these capillaries collapse. Under these circumstances, no gas exchange actually takes place in the affected alveoli, and they become part of the physiological dead space. Easy to remember that in zone 1, alveolar pressure is highest, followed by pulmonary artery pressure. But normally in healthy adults, pulmonary artery pressure will be just higher in order to maintain the blood flow. Then pulmonary vein pressure is obviously lowest. Thus, in zone 1, perfusion is crap. In the middle portion of the lungs, the pulmonary artery pressure exceeds the alveolar pressure. Perfusion is good, and so ventilation is good. Finally, towards the base of the lung, alveolar pressure decreases and pulmonary blood flow increases as the arterial pressure increases. In the lower portions of the lungs, alveolar pressure is lowest than the pressure in all parts of the pulmonary circulation. Again, recapping the apex of the heart, focusing on the pulmonary artery pressure. If this drops, no gas exchange takes place. You thus have physiological dead space. Let's look at the pulmonary blood flow in more detail. Here is the right side of the heart, which pumps deoxygenated blood to the lungs. The lungs can be divided into 3 zones. Gas exchange occurs in the lungs, then the pulmonary vein will return the newly oxygenated blood to the left side of the heart. To the middle zone of the lung, perfusion is good, ventilation is good. However, remember, perfusion to the apex of the lung is poor. You have decrease in Q. Ventilation is lower at the apex of the lung, but not as bad as perfusion at the apex of the lung. Thus, VQ ratio is high here. As you go to the base of the lung, ventilation increases, but perfusion increases a lot more. So your VQ ratio will decrease at the base of the lung. So in summary, your ventilation, the amount of gas you breathe in, increases from the apex of the lung to the base of the lung. But your perfusion, the amount of blood flow going to your lungs, going to your alveoli, increases a lot more from the apex of the lung to the base of the lung. And so your VQ ratio decreases from the apex of the lung to the base of the lung. So I just wanted to talk about one more thing about venous return to the left side of the heart. I wanted to introduce the waterfall effect, whereby the height does not actually influence blood flow. So here, looking at an example, distance as in the height, as in towards the apex, and blood flow, we would assume that blood flow coming from the apex would be highest. But just like the waterfall, the height of the waterfall has no influence on flow. So in summary, your ventilation, the amount of gas you breathe in, increases from the apex of the lung to the base of the lung. But your perfusion, the amount of blood flow going to your lungs, going to your alveoli, increases a lot more from the apex of the lung to the base of the lung. And so your VQ ratio decreases from the apex of the lung to the base of the lung. Again, ventilation is the amount of gas, oxygen, coming into your alveoli, ready for gas exchange. And perfusion is the amount of flow to the lungs, the red blood cells to the lungs, ready for gas exchange. The average VQ ratio through the whole lung is about 0.8. The VQ ratio can change drastically depending on diseases. So let's take a look at some examples here. So here again is your heart. The right side of your heart will pump blood to your lungs through the pulmonary arteries here in blue. The blood will go to the alveoli eventually, gas exchange occurs, and new oxygenated blood will go back to the heart via the pulmonary veins colored here in red. Now in different diseases, ventilation and perfusion gets messed up. Imagine you breathe air in to your alveoli. This is ventilation. Normal VQ ratio is about 0.8, which really means you have a higher perfusion than ventilation on average. In pneumonia, for example, where you have consolidation, you have decrease in ventilation, you don't get enough gas moving into your alveoli. As a consequence, your ventilation perfusion ratio is low. Similarly, if you have mucus thickening and buildup along the airways, like in COPD, you get reduced gas coming into your alveoli, and so you have reduced ventilation. Thus, your VQ ratio is decreased. Another example of a decrease in VQ ratio is in pulmonary edema, when you have fluid overload in your lungs. This results in reduced ventilation. There is reduced gas traveling into your alveoli, where gas exchange should take place. And so you can see spectrum of VQ mismatch, whereby on the left side, your ventilation is decreased. So does your VQ ratio. On the very end of the spectrum on the left side, you can have one area of the lung where the ventilation is 0, which would mean that in this area, the VQ ratio is 0. When this happens, this is called absolute physiological shunt or absolute pulmonary shunt, where you have perfusion without ventilation. With this scenario, you can imagine no oxygen is coming into the alveoli, so you get net low oxygen levels leaving the pulmonary system, and you still have all that carbon dioxide because you cannot breathe it out. You have perfusion, but no ventilation. Now back to COPD. We mentioned how mucus buildup causes reduced ventilation. But in COPD, you can also get destruction of the pulmonary capillaries supplying the alveoli. And so when this happens, you get a reduced perfusion because you're destroying the blood flow to the alveoli. So I mean, in COPD, like in many other lung diseases, it's a fine balance of reduced ventilation and reduced perfusion. Reduced perfusion in COPD occurs more in late stages of the disease. As the VQ ratio spectrum moves more to the right, your VQ ratio increases. It increases until the middle, when you get a ventilation and perfusion ratio about 1, which is ideal. Here you get enough air entering the alveoli, and you're getting enough blood flow to the alveoli. In real life, the average humans, as mentioned, have a VQ ratio of 0.8. However, as the spectrum of VQ ratio moves to the right, you have an increase in VQ ratio, which means you really have a decrease in perfusion. You have a decrease in blood flow to the alveoli. The example of this is the damage to the capillaries as seen in late COPD. Another good example is pulmonary embolism, where a clot occludes the pulmonary capillary or artery, causing reduced perfusion, which will subsequently increase the VQ ratio, causing a mismatch. When the perfusion to an area of the lung is so low, the number could really be anything, because it will depend on the top value, which is ventilation. When perfusion is 0 to an area of the lung, the area is called an absolute dead space, which really means that gas is actually entering the alveoli, but does not participate in gas exchange. And so this space is dead space. The trachea, for example, is dead space because air flows through here, but the trachea does not participate in gas exchange. So I hope this video on ventilation perfusion makes sense. Thank you for watching.
Now, let's a little bit talk about dead space and add some important points. So, what is the dead space? Dead space represents any air in a respiratory system that is not exchanging oxygen and carbon dioxide with the pulmonary capillary blood. The most important dead space for our purposes is the anatomic dead space. In addition of anatomic dead space, you also have to know about alveolar dead space and physiological dead space. First, let's a little bit talk about anatomic dead space. Anatomic dead space is an airway region that, because of anatomical functional structure of its tissues and organs, are not capable of oxygen and carbon dioxide exchange with the blood. Anatomic dead space includes the conducting zone, the nose, pharynx, larynx, trachea, bronchi, bronchioles, and terminal bronchioles. Again, the volume of the anatomic dead space in mils can be approximated by the person's weight in pounds. Thus, a 150-pound individual has a dead space of 150 mils. Now let's talk about alveolar dead space. Sometimes an embolus may block an artery or arteriole in the lungs. As a consequence, the blood flow to the alveolar is disturbed and in spite of the presence of the air in alveoli, no gas exchange occurs here. Therefore, from a functional point of view, these alveoli must also be considered dead space. So again, alveolar dead space refers to alveoli containing air but without blood flow in the surrounding capillaries. Under normal condition, the alveolar dead space is considered to be 0 mils. There should not be alveolar dead space. Physiologic dead space. Physiologic dead space refers to the total dead space in the lung system. It is anatomic dead space plus alveolar dead space. So if you know the physiologic dead space of a patient, you can determine the presence of alveolar dead space. You can determine does the patient have alveoli that are ventilated but not perfused. Suppose if they give you a patient weighing 150 pounds, they determined physiologic dead space of 300 mils in this patient. Can we determine if lung alveoli are being normally ventilated but not perfused? Can we determine alveolar dead space? Yes, we can. First of all, it is very important to know what is the normal anatomic dead space in a person who weighs 150 pounds. Of course, I have already said that the volume of the anatomic dead space in mils can be approximated by person's weight in pounds. Thus, a 150 pounds individual has an anatomic dead space of 150 mils. In this patient, the physiologic dead space is more than anatomic, 300 mils. This brings us to a very important point. When a physiologic dead space is greater than the anatomic dead space, it implies the presence of the alveolar dead space, meaning somewhere in a lung, alveoli are being ventilated but not perfused. Normally, physiologic dead space should be equal to anatomic dead space. In this part of the video, we'll talk about anatomic dead space gas composition at the end of expiration versus at the end of inspiration. It is important to note that end of expiration means it is just before inspiration begins, since breathing is cyclic in nature. Consider the lung as a simple balloon model. The neck of the balloon is the anatomic dead space and the remainder the respiratory zone. The respiratory zone is a very constant environment and the partial pressure of gases in the alveolar compartment changes very little during normal rhythmic ventilation. The partial pressure of oxygen here is 100 millimeters of mercury and carbon dioxide is 40 millimeters of mercury. When a person breathes out, the first 150 mils air comes out from the anatomic dead space. The respiratory zone pushes out 500 mils, but it divides into two parts. The first 350 mils will be expired out. These 350 mils with previous 150 mils compose the tidal volume, 500 mils. The remaining 150 mils air which comes from the respiratory zone stays in a conducting zone in an anatomic dead space. This means anatomic dead space in the end of expiration will be filled with air that originated in alveoli or respiratory zone. Thus, at the end of expiration, the composition of the air in the anatomic dead space is the same as alveolar air. The partial pressures of oxygen in anatomic dead space is 100 millimeters of mercury